and today we are talking about the Framework Convention on Tobacco Control, Challenges and Prospects for World Health Organization. We have, as Formiche and Healthcare Policy, our two sister publications, we have published a paper on harm reduction and on this exact subject, on the fact that it's time this year to talk about the issue of harm reduction, especially in the context of the now postponed Conference of the Parties that was supposed to be held in Panama. But the issue is there, is on the table. And so we wanted to have an open discussion with people coming from all over the world. Today we have representative of the sector of different backgrounds from Europe, the Middle East and Africa, North America, South America, and this wide range of guests and speakers will help us, discuss about this thorny issue, because it's an issue that has not been handled, in our view, with the correct openness and scientific approach, which is why we are organizing this webinar, which is why we published our paper, and which is why we are trying to get as many voices involved in this issue as possible. So let me introduce our speakers today. We have Maria Alejandra Medina, who is Technical and Regional Coordinator at Corporación Acción Técnica Social. Welcome. We have Anders Milton, who is a physician and former president of the World Medical Association and president of the Swedish Snus Commission. We have Riccardo Polosa, who is professor at the University of Catania and founder of the Research Center for Smoking Harm Reduction. And we have David Swenner, professor and chair of the advisory board of the Center for Health Law, Policy and Ethics at the University of Ottawa. And we also have a video contribution by Marewa Glover, director of the Center of Research Excellence, Indigenous Sovereignty and Smoking. And we are also waiting for another speaker who I will introduce as soon as she connects. So let me start by giving the floor to David Swenner. We would like to hear from him, also especially what's happening right now in the context of the Conference of Parties and what's the, global situation in the harm reduction debate, and what can be done better, and what are the perspective on this sector. Thank you very much.
Well, thank you. I was the first lawyer in the world to work full-time on policy measures to reduce the harms from cigarette smoking, starting over 40 years ago. So I was already involved in the field for quite a while before the Framework Convention came along. I was actually critical of the idea of a Framework Convention. And the reason for that is that when you do a convention like this, you have the risk of taking what should be guidance, taking something where we're still trying to learn what to do, doing things better, finding out from each other, experimenting, and you turn it into dogma to say, we now have the answers, you need to do exactly this. So it becomes like a recipe that gets enforced on people. That's a big problem. And we've seen that problem before on things like the international drug protocols that were pushed by people who had an abstinence-only view, that were not open to the science, that wanted an absolutist approach. And they ended up coming out with international rules that tried to bind the rest of the world on issues of what came to be known as drugs or narcotics, and then stood in the way of countries that were trying to modernize their approach to no longer have a war on drugs, to have a public health approach to things like marijuana. And I think we've run into the same problem. We've ended up with people who really didn't know the issue well, who were meeting behind closed doors, so very illiberal. There was no scrutiny of what they were doing by outside experts. And they were coming up with rules to say, here's what you need to do. But many of what they were saying really didn't make sense on the basis of the science that already existed and the practicalities that we know of what works in public health. So we ended up with ignoring important things like differential taxation for differential risk, something I've written about with others in the New England Journal of Medicine. We ended up saying you have to have certain types of warnings without evaluation of whether these are really the most effective approach to take. And certainly if you don't have clear steps people can take to deal with the danger. We ended up with a law that says the interests of the tobacco industry are totally irreconcilable with public health, despite the evidence from places like Sweden that a tobacco company played a huge role in a public health breakthrough of replacing cigarettes with a very low-risk product called snus. It stood in the way of even the production of vaccines here in Canada by the World Health Organization refusing to authorize a vaccine because which would have been very valuable in dealing with COVID in developing countries, because a tobacco company had a minority interest in the company that developed it. So it's to say, we are so mad at what they did to cause disease in the past that, my gosh, we're going to cause disease now by preventing anybody from doing something to counter it. I mean, this is silliness. And it's similar to what we did see with the drug protocols. I think that this sort of closed discussion by poorly informed people who are driven by ideology, by political or religious beliefs, rather than public health principles, is a real problem. And then when the World Health Organization seeks to defend this or refuse to listen to any critiques. So I was one of a large group of international experts that wrote a letter to the World Health Organization pointing out the problems we were facing because of their opposition to harm reduction in this field when they're so accepting of harm reduction everywhere else. And they ignored us. They will not talk to us. That is a problem. And that's what happens when something that should be instructional, should be guidance, becomes dogma. It is treated like religious law. You're a heretic if you dare to question it. So we need to get past that, because that also calls into disrepute the whole field of public health. The public stops paying attention to bodies like the World Health Organization and domestic health organizations when they're saying things that people know to be nonsense, that it's harming people's health rather than assisting. And we really need to pay attention to maintaining credibility for public health authorities, because it's so important on so many things, including what we've just recently been going through with COVID. And the bottom line is that we have known for decades that the reason people die from smoking is because inhaling smoke, not from nicotine. We know that the countries that have had the biggest declines in cigarette smoking in recent times are countries that are essentially ignoring the advice of the World Health Organization. Places like Sweden, Norway, Iceland, Japan, places that have allowed substitutes to replace cigarettes. So we know that we could eliminate or largely eliminate the smoking problem globally by substituting low-risk products. The opportunity is there, and things like the Framework Convention and the World Health Organization should be facilitating that rather than standing in the way. Thank you.
Yeah. Thank you. Thank you to David Schreiner. And now I go to Dr. Folosa. And talking about letters, you've also wrote a letter, this time to the European Commission, to the European Union, also on the subject of harm reduction, also on the fact that in Brussels, it seems to be, we seem to see a similar kind of, deafness to the concept and to scientific evidence and to the part of the scientific community that is pushing for an approach that is science-based and evidence-based instead of the same, kind of religious opposition to any kind of, concept of harm reduction in European law. What is your experience, your current experience in this field? And tell us a little bit more about this letter and how you see the European Union moving in this field.
my impression is that the European Union is moving on the same footsteps as the WHO bureaucrats. It seems that they keep reinforcing each other's on the same arguments and nonsensical arguments that they are using against, reduced risk in general. We wrote a letter simply to try and underscore the fact and the evidence that it is not true that that combustion-free products are dangerous, or at least as dangerous as tobacco combustibles. I mean, there's now plenty of evidence that shows that these devices and these vaping products, these heated tobacco products, are at least 80 to 90% less toxic compared to combustible cigarettes. I think the fight against tobacco is a crucial challenge for public health, but not just because it's a challenging at the public health level. As David was mentioning, we now have a solution to the problem, and we seems to be completely blindfolded, particularly in the places where people should be responsible for making oculate decisions. And it's not merely an individual issue, but it's a problem that demands immediate collective action. The problem is this collective action seems to recruit people from different sides of the debate, and seems to recruit more people from one side of the debate than from the other. In our experience, we are producing, for example, excellent science, but our excellent science is completely snowed under by junk science that is constantly being produced, particularly by US-centric narratives and US-centric funded institutions, that they look very respectable on paper, but in reality, they are supported by the very, I'm sure David can correct me if I'm wrong, by the very tragic mechanism, which is called MSA. So basically, the money generated by tobacco combustibles is going to fuel the government, then relays back the money to all these organizations, and it creates a massive conflict of interest that nobody's talking about. So, and of course, the whole narrative is against vaping because they are not stupid. They already understood long ago that vaping can desertify, tobacco. Conventional tobacco products, and that will create problems in terms of receiving less money through this diabolic MSA system. And I'm sure probably David, who's very, very well acquainted on this, can say something more about it. In my view, it is crucial to adopt robust and sustainable policies that can shield future generation from tobacco dependence and from the damage of tobacco combustibles. We already mentioned cardiovascular problems, cancer, respiratory condition, and so forth. But these are specifically caused by the combustion of tobacco, and not by vaporization of a liquid or vaporization of nicotine. Of course, there'll be some level of absolute risk that needs to be investigated, but the overarching level of science available today shows very clearly that this level of concern is at least, 5 to 10% the level of tobacco combustibles. So I think it's essential also to ensure that these policies will adopt and respect human rights. This is another important point. So tobacco control policies today need an innovation. Tobacco control policies today need to think in the 21st century mode. So beyond advocating the actions like increasing tobacco taxes, implementing public smoking bans, promoting accessible cessation programs for all, okay, these tobacco control policies should also take into account the integration of the principle of risk reduction through the promotion of non-combustible alternative products for adult smokers. And you see this happening already in places like Japan, Norway, Sweden, England, and Iceland. So, I mean, I'm not sure if we are the right people or the gifted people that will be able to influence WHO big cookies or people at the high levels in the EU Parliament, but clearly we must act now urgently and resolutely to address and create a tobacco-free future for the next generations.
Thank you. Thank you to Riccardo Polosa. In a couple of technical, notes, this video is available on formiche.net. It will be on YouTube, so people can watch our webinar even after it has been concluded. And people who are connected on Zoom right now with us can make questions with the Zoom question box, and at the end, if we have time, we can read some of them to our speakers, so that there can be a little bit of a discussion. And I know since a couple of speakers need to leave early, if you have questions for Doctors Polosa and Swanner, please write them now. And now I will, engage Maria Alejandra Medina. Dr. Polosa has talked about human rights. You are connected from Colombia. You know very well the situation in the whole region. You've been following it. You've been studying the issue of harm reduction and human rights. And so please tell us a little bit about your perspective from your region, because what we have known and what we have seen with the papers that we have published with Formiche and Healthcare Policy is that there are so many different approaches all around the world. We touch upon some of them in the pamphlet. We touch on the most probably the most virtuous one, and then we talk about in our pamphlet about China, about Turkey, about situations in which the situation is it's quite dire, and it's getting actually worse with time, while we have very good practices all around the world that give us some direction. So what is the direction Colombia and in general Latin America is taking in this issue, Ms. Medina?
So thank you. I am the coordinator of the nicotine harm reduction platform in Colombia and Latin America. And in our NGO, we work in both legal and illegal drugs, and with the harm reduction focuses. We provide some services between drug checking and even from tobacco users and nicotine safer products. We give information in different places and in different contexts. So to address today's panel and the question, I would like to first share our recently communication and advocacy campaign. We talked with the Minister of Foreign Affairs, Minister of Health, and Minister of Justice in Colombia to advocate to this meeting, to COP. And through videos, infographics, and short articles, we explained the COP agenda. We positively impact over 15,000 people, informing them about COP decisions, informing about risk of the harm reduction focus in these meetings, and decisions that can affect access for smoke-free alternatives to tobacco. So we engaged new audiences in a traditional, unusual topic with the challenging that people do not access to this information that affects them in their daily lives. And especially when we talk about an extremely closed international scenario like COP and like this role of WHO with many barriers to accessing for the decisions. This may seem distant, but we managed to bring it closer to the immediately reality of the tobacco users and smoke-free users too. And even users of other drugs who are affected by this kind of prohibitions and this kind of focuses uh, because there are very restrictive approaches. So on the other hand, mentioning that Colombia under the new government is promoting a 10-year drug policy that includes harm reduction for both legal and illegal drugs. However, there is a contradiction between Colombia's paradigm shift and the status quo in the COP and the Framework Convention of Tobacco Control. We achieved some open spaces, but unfortunately, many preparation meetings in Latin America, like in Brazil and in other countries, were closed and didn't allow to civil society participation. So it's incredible for example, in the leadership that Colombia it's taking in the region, is willing to speak at the United Nations against the war on drugs, about decriminalization of coca leaf, for example, and our government is talking about in international platforms about harm reduction services of drugs users. But when we talk about tobacco, when we talk about smoke-free alternative, doesn't even dare to open the debate on harm reduction and this effectiveness in COPE, for example, and the risks of this approach in Framework Convention on Tobacco Control. So with this context, I would like to argue the following points regarding the discussion that were supposed to take place last week, but we already know that there was canceled and it's postponed by the WHO to the next year. So first, I want to say that the COP is not telling the difference between nicotine and tobacco and the alternatives that are potential and are solutions for too many people. So this keeps like misinformation and confuse users about the profile risk between different products. And the recent increase in broad information about vaping in Latin America the last 2 weeks was incredible. There was so many fake news in Brazil, in Argentina, in Colombia, in Panama, like trying to confuse audiences before COP. Second, by no difference in this between don't give any information about differentiation between various smoke-free nicotine products, and this COP hides too many evidence, the developments, and this is really bad to innovation products, and this is really bad to new forms to approach to smoke or tobacco use, and even for drug use too. And not involving nicotine consumers in the regulation process violates their human rights, as the other panelists already mentioned it. And this is very violated a lot of human rights of users, because we are trying to understand new approaches in health policy and new approaches in human rights. And COP, it's in another way, it's in another decade, I think, this approach, and it's getting too hard and it's getting too prohibitionist too. So I want to close my intervention saying that we cannot regress to prohibition measures that have adversely affects consumers of drugs, even if they are legal or legal. We need to be very aware of the intensified discussion due to COP postponement. And we must emphasize that the current tobacco control policies are creating more harm than many products that today represent harm reduction alternatives for many users. And also, we cannot turn this into a new war on drugs, like war on tobacco or war on alternatives, within all the errors and costs in health, in information, in finance, and human rights shows the war on drugs. So we have to deal that there is no possibility to like like tobacco free or nicotine free world. We have to deal with that, and we have to give more innovative focuses like harm reduction, innovative products that we already have, and we have to change this approach early, because there is cost, many like health, money, and it's like human rights issue too. So thank you for your attention and for inviting me to this panel.
Thank you to Maria Alejandra Medina. Let me go back quickly to David Swanner. You mentioned Ms. Medina has mentioned the question of secrecy, the question of the fact that consumers are not part of the debate, that the Conference of the Parties, and also meetings leading up to the Conference of the Parties were closed door and not easily accessible to parties concerned, because it's very I think it's very interesting that a subject as like tobacco use, that has been at the center of public debate for almost 50 years now, is getting less and less accessible to subjects that can give their own points of view. So do you think that from now until the COP, whenever it will take place, something might change, or there might be some kind of different approach on this secrecy and this not this failure to involve subjects that are crucial to this debate?
I'm not optimistic. I mean, this has been done very secretively by small numbers of people who, as I say, are in many cases are very ill-informed on the topic. These are not people who have spent years studying this. They are not people who are open to new ideas. In many ways, they're the sort of people that we saw with US alcohol prohibition, or the war on drugs, or the efforts to prevent women from having access to contraception, that they're people who are trying to use the power of the state to impose their moral views on the behavior of others. And they see any outside view as being some sort of heretic, that they have to be dismissed. This is, of course, just a terrible way to make law. It's incredibly illiberal. This is not how democracies work. We end up with bad policies. And we also are dealing with a well-known phenomenon in social psychology, which is that if you get people together who already have very similar views, and you get them to try to reach a consensus on something, the small group processes, as they try to identify with each other and become ever more a group, is that they become even more extreme in their views. And that's why we end up with these prohibitionist sorts of policies. That's why they don't want to hear anybody who questions them. That's why they think that this is an absolutist approach, and that they don't even need to listen to the people whose lives are on the line, the people whose lives they should be trying to save. So what motivated success on things like dealing with AIDS is the nothing about us without us. If you're talking about people and what they're doing and you're trying to reduce their risks or save their lives, you need to involve them. You need to listen to them. And if there are better ideas out there, if people think they've got better ideas in what you're doing, you need to listen to that. And if you're coming out with policies that have huge negative consequences and people are pointing this out to you, you don't dismiss it. But this is the dynamics that they do something behind closed doors. The net result is that we get something like we're now dealing with the international drug protocols. Because these provisions are primarily voluntary, countries just decide to ignore them. You know, that's why countries like mine have legalized marijuana. We can ignore international drug protocols. You know, they were silly, they got in the way, they held back progress for a long time, they hurt public health. The same with policies on safe injection sites and supplying clean drugs and drug testing and various other things we can do to save lives. Countries end up ignoring protocols that are anti-health, that are anti-consumer rights. But as I was saying before, what happens in that is that people also lose faith in authorities. They stop believing the World Health Organization and others on other topics. And that's a huge cost. And we're seeing that happening globally now, where authorities are no longer trusted. And we're seeing authorities doing things that, as Peter Sandman has said, when public health people say, why don't they trust us? The real question should be, why aren't we trustworthy? And that's what they need to address. How do they become trustworthy?
Thank you. Thank you. Now let me go to Anders Milton and the Swedish case, which is quite a unique case in Europe. And it's consequence of a particular political history, because when it dates back from when Sweden joined the European Union, and it had this special status in which it could continue the sale of alternative tobacco products that have now made Sweden a case study in the reduction of lung cancers and other illnesses related to tobacco consumption. So to Anders Milton, I'm asking, how do you see right now the situation in Europe? Why can't other European countries follow Sweden's approach? We know that Sweden, the main particular product that is sold in Sweden is called snus. And we also have one of our viewers that is asking, what are the scientific evidences that snus is better than using smoking a regular cigarette? Aren't there other types of cancers maybe associated to that? Thank you.
Thank you very much, and thank you for inviting me. As you know, there are 1 billion plus smokers in the world today, and 50% of them will die unless we do something. It's on that level. So it's 500 million will die without us doing anything. I'll try to answer the question that you posed. Different Swedish governments have done basically what the others in the European Union have done. I mean, we have made smoking more difficult. You don't smoke in restaurants, you don't smoke in cafes, you don't smoke outside a cafe or a restaurant either if you sit down. Nowadays, smoking is not seen as a good thing. We have snus, which is something that tobacco or that you put in your mouth, under the lip, or nowadays you can use white snuff, which is just nicotine, and nicotine which is dissolved in paper, really. So I mean, we have 5% of the men that do smoke daily, which is probably the lowest figure in the European Union, and probably the lowest figure in the world. but we have 17% of the men that use snus daily. As a matter of fact, there are more women that smoke today in Sweden than there are men, because they don't use snus. Had the European Union used snus and smoked the way Sweden does today, in the last sort of 30 years, we would have 350,000 deaths fewer per year of men dying from lung cancer or effects of smoking. So it's quite heavy, you know. And as you know, when the European Union decides to discuss or they want to beat cancer, you know, the European Union beats cancer, they don't talk about smoking at all. We try to get that into the picture, but they don't want to talk about that. So I mean, all these authorities are, including the Swedish health authorities, are influenced by the World Health Organization. And as you know, the World Health Organization wants to forbid everything but cigarettes, really. And I think that's the wrong way to go. I think we should use harm reduction instead. Snus is not a health product. You know, there are instances where you should use snus. For example, if you're pregnant or if you have other things. But on the other hand, it doesn't give you cancer. You know, there are a lot of studies on snus, and it doesn't give you cancer. Smoking does, you know, but snus doesn't. And we have, from the Snus Commission, we have tried to be truthful, you know, because we want the Swedish public to trust us. We only use official statistics, be either World Health Organization statistics or European Union statistics. There is nothing homemade whatsoever. We are persistent. And you have to be, because you're going to meet people that are of different persuasion, and they say that you should forbid harm reduction because it doesn't help people. Because snus is creating a dependency, of course, because you are used to getting the nicotine daily, and it in that sense it creates a dependence. And yes, that's true. Snus, tobacco or nicotine rather, gives you a dependence. However, when we look at the figures of Sweden, you know, I mean, 17% of the men use snus daily, 5% or perhaps less today smoke daily. It's about 23% of the male population that use nicotine daily. It's about the same as in many other European Union countries. The difference is that in Sweden they don't die. You live with the snus, but you die from cigarette smoke. And the question is it a unique Swedish experiment? I mean, or could it be translated into other countries? To tell the truth, I really don't know. You know. On the other hand, on one hand, you have to have authorities that accept that snus is less harmful than smoking. And snus you can use when smoking is not forbidden. I'm sorry, when it's forbidden. You can use snus in the house, in the restaurant, in at your job, but you cannot smoke or vape. So it's in that sense easier, and it gives you the nicotine kick. It creates a more a sharper mind, you could say, and it does help you in that sense. And I think that, again, I mean, it's important to be truthful. Don't do what the tobacco industry did before. I mean, 30 or 40 years ago, they lied. And I think that part of what is happening today is that we are paying for the fact that the tobacco industry lied before. You know, I was a member of the commission, the public health commission that Gro Harlem Brundtland, the then Director General of the World Health Organization, established. And she really believed that her telephone was tapped by or listened into by the tobacco industry. Those were the relationships between health organizations and the tobacco industry. I don't know if it was or not. I don't know. But I mean, she was convinced that her phone was tapped or was listened into. And I think that, again, we are paying for that, for those problems that people did, because the people that work today in the tobacco industry, they don't know this, obviously, because nobody tells them, you know. It's David Sweeney and some others and me who could tell them, but they don't know it. And I think, again, be truthful, be persistent, and only use public statistics. You know, simple as that. Tell people the truth, you know, because people want to live. Again, the 1 billion smokers of today, if we could help them so they won't die from smoking cigarettes, we have done a great thing. And I think we are trying to do that. And as you perhaps know, the Swedish government a couple of weeks back decided to increase the taxes on cigarettes and lower them on snus. And it really is the first time that the government has done something which is harm reduction. And the agencies, the health agencies, are not interested at all whatsoever for the time being. And we are working a lot with them, and we're trying to convince them to change position. But they are very much into the World Health Organization scheme. And we are what we are using is, you know, the truth, the statistics, the fact that you die from smoking, but you can live with snus or something else. Thank you.
Thank you, Dr. Milton. So as I was telling our viewers, we try to have the broadest panel possible. We also have a speaker from New Zealand. Unfortunately, due to the time difference, she sent us a video because it would have been too late in the middle of the night for her to participate. So I will now please ask my colleague to send to play the video of Marewa Glover, who is a behavioral scientist and an expert on this issue. And New Zealand is a very interesting case study. It's also on our paper. So let's hear it from Professor Glover.
Thank you for inviting me to join you today to talk about some of the challenges for the Framework Convention on Tobacco. Thank you for inviting me to join you today to talk about some of the challenges for the Framework Convention on Tobacco. The Framework Convention on Tobacco.
I'm sorry, I think we had a problem with the video. We'll try to play it a little later. I think we had a problem with the streaming and also with the recording. So, okay, so wait, we'll start again.
To join you today to talk about some of the challenges for the Framework Convention on Tobacco Control. In New Zealand, adults who smoke have access to vaping products and heated tobacco products, although not many know about heated tobacco products as advertising is banned. This graph shows that smoking prevalence reduced more rapidly as vaping prevalence increased. Now for some preliminary results from our Voices of the 5% study, a longitudinal qualitative research project. We recruited 62 diverse adults from across New Zealand, aged 19 to 81 years old, who did not want to stop smoking, or they believed they would not be able to stop by 2020, New Zealand's smoke-free goal date. For this analysis, data was extracted from interviews with 50 of the participants who talked about smoking, what harms smoking causes, and how the damage occurs. Doubt or rejection of smoking harms messages is a barrier to quitting. Many participants had shallow recall of the diseases smoking causes. They had poor understanding of how smoking causes damage to the body, or what it is in the cigarette that causes damage. Few said anything about inhaling smoke. Some doubt the smoking causes messages because family or friends who had smoked for decades didn't develop smoking-related diseases or didn't die early as the messages had warned. Some rejected the messages because they lacked nuance. These participants appeared to know that there was a dose-response relationship between consumption and harm, and they believed other determinants played a role. For example, they said everyone's different. Many said they don't know. Misinformation about nicotine is a major barrier. Over 2/3 of our participants expressed uncertainty about what nicotine was. Many believed it was addictive. Many believed nicotine causes the harms associated with smoking. Some participants rejected the misinformation about nicotine, and a few expressed distrust of public health messages more generally. Overall, a majority didn't know much about nicotine or had negative beliefs about nicotine. In conclusion, believing that nicotine causes the diseases associated with smoking or having doubts about nicotine can deter people from using risk-reduced nicotine-containing products. The literature shows that the absorption of the misinformation about nicotine has put people off using nicotine replacement therapies and vaping. This is a major barrier to the adoption of risk-reduced nicotine products and thus to the more rapid elimination of smoking-related diseases. Thank you. Thank you for inviting me.
So thank you to Professor Glover. And so we also had this New Zealand example. And I wanted to go back to Dr. Polosa, who I know he has to leave very soon, but our webinar will be over in about 10 minutes. So we have time for some more debate on these international case studies. What is the best path that you have seen, Dr. Polosa, in these years? What are the countries that are moving in the best directions? And I want to ask something to all our panelists. What do you think, for instance, is China's influence on all this process, on everything that we've been talking about? Because we do know how China is important in terms of conventional cigarette production, on the monopoly that it has, and on how on one side, it basically bans all kinds of alternative products, but on the other hand, produces a lot of vaping products and then sells all over the world. So I just want to, ask to our participants, why there are so many different approaches, and which one could be the easiest also to follow, and maybe a comment on the New Zealand progress, because we also have some New Zealand news coming in these days.
Well, there are multifaceted aspect of the progress, because we are dealing with multifaceted design of the product and multicultural domains. So if you put this together, you will end up having a large diversity of outcomes. But My personal take is that vaping is winning and combustible cigarettes are losing. And you can just see it from what is happening in amongst the youth. Young people are not smoking anymore. There is eradication of smoking amongst students, school students, college students, at epic proportions. Something has never been seen before. Of course, many of those are switching to the new fad, which is vaping, mostly disposable. The real question is how these two situations are comparing. Of course, addiction is still on the equation, but in my opinion, addiction from vaping products cannot be as worse as an addiction from combustible cigarettes. And the federal data from US proves it. If you look at the data in 2019, there was a peak of students and college students using vaping products. Over a few years, there's been a massive decline. If the product was so addictive, we would never ever seen such a massive decline. So basically, that explains, even without relying on scientific studies, I'm aware of scientific studies that are already showing that the level of addiction of electronic cigarette is much less compared to combustible cigarettes. But, you know, this, in a way, is something that should be repeated constantly to politicians and to the public, because they really think that the level of addiction is similar when, in fact, it is not. Another aspect which maybe have a relevance is the level of damage to the lung. Of course, electronic cigarettes are not risk-free. We've been repeating this mantra over and over again. And of course, WHO has been trying to scaremonger population and the public by saying, oh, look, the electronic cigarettes are vaporizing, you know, how do you say, anti-ice battery kind of products that I remember in 2012, this was something very hot on the headlines. People saying that the electronic cigarettes were containing, I think it was a diethylene glycol, you know, one of these products that are used as a coolant in the batteries. And of course, nobody's talking about this anymore because there were maybe occasionally news that they were used just to scare people about vaping products. And the same pattern has been repeating itself over and over again. Just think of EVALI. EVALI, it was an unfortunate event that was associated to some illegal products using vitamin E acetate. But bottom line was that the media took by the storm this idea and made it global, like the nicotine containing nicotines was the culprit. I really think that the bottom line is that we have billions, millions of smokers all around the globe. Many of them do not want to quit or cannot quit, and we do not have a proposal, a public health proposal for these people. So we really need to think in this term. What is the public health policy that will meet their needs? I cannot think of anything else but tobacco harm reduction.
Thank you. Thank you to Dr. Folosa. And we have connected Rania Mamdou, who is a professor of psychiatry at the University of Cairo. Welcome. And so you, of course, as well are a doctor, and you've been studying this for a long time. And so we've had the perspective from all over the world. And So I'm going to ask you again, what is your perspective on the Northern African region, on the Middle Eastern region, but also what is your psychiatrist view on this issue? We've been talking to professionals that have dealt with the problem, also at the regulatory level, at the health policy level. But from a psychiatrist perspective, harm reduction, how does this come into play?
Good evening, dear colleagues. I'm so proud to be with you today, dear colleagues. And I'm going to speak about a national research done in Egypt on addiction. We have a national survey every year about the different substance uses, including nicotine. Now, 40% of Egyptian population, according to 2019 national survey, did use nicotine at least once. The lifetime prevalence for nicotine dependence in Egypt is 40%. And we're a population of 100 million citizens. So 40%, we mean 40 million of the Egyptian population did try the nicotine at least once per life. From my point of view, this is not the real number. It should be more than this. My opinion, we have lots of nicotine users in Egypt, much more than the 40%. But another point, the harm reduction approach. Harm reduction approach it's an approach used in psychiatry maybe more than 35 years ago. The harm reduction approach did facilitate to us for the treatment of opioid use disorders, cannabis use disorders, amphetamines, with a simple theory that we as human are not like, we differ from our degree of change. If a cardiologist, one of our colleagues in pulmonary diseases or cardiology, said to a smoking patient that he will be entering to make a cardiac stent, or he has a pneumothorax, to stop nicotine, not everyone will listen to the cardiologist or the chest physician to quit nicotine at once, because nicotine definitely has an addictive component beside the carcinogenic component. So the harm reduction approach came to solve the problem of many smokers who had health problems, other side of the addiction, and cannot quit the nicotine, cannot quit smoking because of the addictive effect of the nicotine. So once the cardiologist leave the room inside the hospital, he definitely asks his family, go ahead and give me the pack. Go ahead, I cannot listen to the physician. And he exposes, or she exposes herself to all hazards because of the simple point that they cannot quit the nicotinic addictive effect of nicotine. Harm reduction approach come to solve this problem. That we are not all human can change with the same duration and with the same quality. So in order to help them to at least decrease the health side effects of smoking, and also give them an opportunity to transfer, to shift to other nicotinic but less healthy, risky products that would give them maybe the same amount or less amount of nicotine, but with much less risk on their health. So, and from my clinic, we have lots of worldwide data with the harm reduction approach with nicotine. And we have also neurobiological researches, neurobiological studies that have been happening in Harvard University and with colleagues in the UK. These neurobiological researches pre and post the harm reduction approach for nicotine-dependent people have revealed and resulted that many of them within 1.5 years succeeded from the shift with the non-combustible tobacco, non-combustible nicotine. They succeeded to be with zero nicotine within 1 to 1.5 years after the transfer or the shift to the non-combustible nicotine. So from the psychiatric perspective, the harm reduction technique or harm reduction approach came to solve both problems, the addictive effect of the nicotine and the health risk, the whole risks from nicotine. It's a way of transfer or shift from a very hazardous nicotine product to a less hazardous nicotine product for 6 months to 1 year until the patient can reach zero nicotine in his body. It took for the WHO and for the whole research people hundreds of years to see the negative results and the negative effect of the combustible nicotine or the combustible tobacco. We need also another 70 years to make researches and to come with researches with the effect of the non-combustible tobacco on the people. So we cannot judge now, from my point of view, we cannot judge now the effectiveness or the failure of non-combustible nicotine without taking the same years and same evidence-based researches to see the effect of those non-combustible tobacco, as well as we took hundreds of years to see the researches about the combustible nicotine. If we'll be talking clinically, all the patients are referred from the chest clinics in our university and cardiology clinics of our university to our nicotine clinic. We have a nicotine clinic daily, and we receive about 40 patients a day. We encourage them to have the nicotine gum, the nicotine patches, the nicotine sprays at first. And if they cannot and need further assistance with further nicotine in their body, we do encourage them to use the non-combustible nicotine products for 6 months. Then we help them with another 13 exercises of CBT exercises that help them to decondition from the usual addictive behaviors accompanied with the nicotine use. So with a 4 months nicotine program in our clinic, we make the exercises needed to decondition the patients, and also the nicotine replacement, and we liaise with our colleagues in the chest and cardiology to help the patient psychiatrically and physically to quit nicotine. This is my experience clinically, and definitely we need other independent evidence-based researches to detect the effectiveness of the non-combustible nicotine. And I think that these products need to have their time and duration and researches, just like the other combustible nicotine took from us hundreds of years to see their effectiveness. Thank you so much.
Thank you, Dr. Mamdou. So I just want to ask our panelists if they have any quick final words for our viewers, and if not, we can also, end our working session today. Let me know.
If I could just quickly, if we look at the history of advances in public health and human well-being, the principles of the Enlightenment using science and reason and humanism, and we combine that with the principles we know that work in public health of understanding people's lived experience, meet them where they are, and empower them to make better decisions. We combine those things with what we now know about nicotine and alternatives to cigarettes, and we've solved this problem. And we have that opportunity. We just have to be able to move on it and avoid all this ideological, moralistic baggage that's been holding us back. So the opportunity is there for one of the biggest breakthroughs in public health history.
Thank you, Dr. Swener. Dr. Milton, and then Maria Alejandra Medina.
I would like to support what was just said by David Swener. I think it's very important that the public health oriented people are truthful and that they don't have something that they need to fight for without the scientific evidence, as it were. And I think that they are making themselves a bad injustice with doing that. And I think it's important that they're trying to use scientific evidence and give people an alternative to smoking.
And I just want to add, and I agree, and yeah, while the World Health Organization remains in the past, I want to add that the daily practice of those who provides harm reduction services, communicating and offering information for users continue. And the reality is that the community level is much faster and more effectively in finding effective solutions of tobacco use than intergovernmental organization. And it's unfortunately, but we will continue to provide harm reduction services to people who will switch from tobacco to an alternative. And regardless of whatever governments prohibit or fail to advance in innovative regulatory approaches or framework, we just, as harm reduction services, have provided for years until government decide to support them and upon realize they are effective. So, however, this is need to be a skill up to the national and public health levels as New Zealand and other cases.
Thank you. One last question that comes from one of our listeners. Maybe we can ask it to Dr. Swener. Is there a one-size-fits-all way of making WHO change its approach to tobacco control policy? If no, how can countries in sub-Saharan Africa who rely heavily on support from World Health Organization and other multilateral organizations approach this and ensure that they have their own homemade tobacco control policies? This question comes from Nigeria. So how can countries that have this big reliance on WHO manage to enforce local tobacco control policies that can be maybe can move away from what WHO is telling them right now?
Sure. Countries don't have to follow WHO, don't have to follow the Framework Convention on Tobacco Control. They can do things that are in the interest of the health of their own people. But I think we're seeing more of this happening globally, of countries saying, we want to do what works here. And what works in sub-Saharan Africa could be very different than what has worked elsewhere. But we also have the ability to rethink this and say, how do we leapfrog over what has happened in other countries? Similar to, not that many years ago, I remember reading that China will never be able to have a good telephone system because there's not enough copper to make the wires for the phones to work. And the same argument was made that Africans will never be able to have phones because there's not enough copper wire and the phones are too expensive. And look what happened. Technology leapfrogged over that. We don't need copper wire. We have mobile phones that have revolutionized life all over the world and certainly in sub-Saharan Africa. And sub-Saharan Africa could do the same here by saying, we're going to take the lead on alternative products. And if the World Health Organization wants to act like a public health organization and respect human rights and pay attention to the science, use reason, show humanism, we're willing to work with them. If they stand in the way of us, we'll move without them.
Thank you. So thanks to all of our speakers. Thank you to those who have listened today. And again, this video will be on formiche.net, and on the same page as the video, which is also on YouTube, you can find the pamphlet both in Italian and in English. So that's the idea. The idea is to gather opinions on this very important topic of harm reduction. Talk about best practices, talk about potential outcomes of a change in health policies that can, favor smokers, patients, and in general the health of the populations of the countries that are willing to, accept the scientific-based approach and, evidence-based approach. So thank you again to everyone who has participated today, and I hope to see you soon on Formiche, and bye-bye.
Bye-bye.
Yeah, thank you very much.
Likewise.
Thank you so much, dear colleagues. Thank you so much.